Hello you guys, welcome to another video and welcome to my channel. If you are new, my name is Zanele Tegiso and I am a registered nurse and I am on YouTube to document my life as a nurse in South Africa. I am so happy. I am so excited to actually be sitting here. Literally I am, you guys. I know as YouTubers we're always saying I am so excited to be shooting this video, but this one, child, this one really makes my heart to swim on a lot of yogurt. Okay, I am so happy. So I just came back from work and I'm checking the date. I'm like, tomorrow is the 1st of December. Tomorrow it is World AIDS Day. And if you are in the public health sector, if you are in the HIV space, if you read about the things that are happening and transpiring in the HIV space, then you will know how far we've come as a country. Okay, so I walk in, I'm like, tomorrow is World AIDS Day, and I'm not gonna have a video up talking about HIV because I've been contemplating on the idea of Vlogmas, right? And I ended up deciding not to do Vlogmas because I'm gonna go to the Eastern Cape and network issues are a lot that side. So I felt I'm gonna shoot content and then not be able to post it up because of network. So I might as well just not do Vlogmas. And today, it is actually World AIDS Day. I said, there's absolutely no way. There's no way that we can have World AIDS Day in the country and me, Ness Z, I keep quiet about it. No, it's not happening. It's completely not happening. I want us to have a casual conversation about HIV, you guys. Right now, I did not even plan this particular video. I don't even have notes. The only thing I have is the ART guideline, which is the National Consolidated Guideline, and it was printed in 2022 in February. So I only have this guideline because there are things that I would like us to go through on the guideline, but I just want us to have a heart-to-heart conversation about HIV as people who are living in a country that has most of its population infected by HIV. So yeah, let's get into the video. I would like us to go through the history of HIV, and we're going to do that by checking it out on our consolidated guideline. There are quite a lot of milestones we've had as a country when it comes to the HIV program, okay? And I want us to just go through them, like from the time where we didn't have ART, you know, to the time when it was introduced in bits and pieces, you know. Let's see where our ART program started and what was happening during those times. So it was back in 2004. That's when South Africa introduced ARVs. And they introduced ARVs not to everyone who was living with HIV at that time. They introduced them with a certain criteria. So you had to be HIV positive, but there were things that they were looking at for them to be able to give you or to put you on ARVs. In April 2004, introduction of ART started, right? And there was what we call eligibility criteria, and which is what I said earlier on to say there were things that they looked at and said, you need treatment, you don't need treatment. And one of those things was that your CD4 count had to be less than 200. So if you don't know what is a CD4 count, basically CD4 count that are fighting for you when you have any kind of infection. So the duty of HIV, or what the virus does in your blood or in your body, it actually destroys your cells, your body cells. It destroys your CD4 count, or it makes your body not to be able to fight for itself against any kind of infection. So they would test you if you were HIV positive and you had a CD4 count that is above 200. They'd be like, nah, we don't think you need ARVs, just go and eat healthy. And to be honest, that did not help in any way. So basically we would wait for people to get sick first We would wait for people to deteriorate before we could give them ARVs. So the available drugs during that time, it was Stavodin, which is a drug that is no longer in right now. It was also amitriptyline was there, efavirenz was there. So efavirenz is still there even now. Amitriptyline and lamivudine, it's still here even now. Stavodin was eradicated in South Africa. We stopped using Stavodin in South Africa because it had vigorous side effects. Like it had side effects that were detrimental on people's health. Like I remember men developed breasts. I used to take body fat and put it to the upper body. So like ishape yabantu besela Stavodin, it goes like this. Yeah, people had a lot of fat up here and then they had no fat on the lower body. So, and men developed breast, so the country eventually stopped using Stavodin, right? And then in 2009 to 2010, we did the national testing campaign where we were testing everybody, like we wanted people to know their status. We robustly went out. I'm saying we as though I was a healthcare worker then. In 2009, I was doing matric. But yeah, I remember when I was in matric, there was an organization that is called Oram Institute. It's still there even now. It even used to give us money and incentives to come and test. Like maybe 50 rand to test a laugh line, guys. Like we were tester and we were given 50 rand for testing. The department was attracting people in various ways to ensure that we are getting tested, right? And also there was the implementation of NIMART. Nurses were being trained in high numbers. The reason nurses had to be trained in high numbers, it's because the country had realized that the number of infections in South Africa was like increasing, right? And not everybody could go to the hospitals. Remember, in the hospitals we had what we called wellness clinic, right, where people who were living with HIV were taking their treatment. And the primary healthcare sector would then refer patients, like they would test patients. If you're HIV positive, you are referred to wellness clinic in the hospitals. So DOH realized that the hospitals are now being full, like there's influx of patients coming in with this disease, right? And they introduced NIMART. Nurses needed to be trained. Primary healthcare nurses needed to be trained on how to manage HIV. Introduction of NIMART and implementation of NIMART happened between 2009 and 2010, and nurses now started to initiate patients on treatment in clinics. So now you didn't have to catch a taxi and go to a hospital to get your ART. Like you would go to your nearest clinic, get tested, get your treatment. And even the hospital started to down transfer or down refer patients that they had on their systems at the wellness clinic to their nearest facilities. I mean, it helped patients as well, because patients, it actually meant patients didn't have to spend a lot of money to go and collect their ARVs. I mean, guys, we all know the majority of our people who are affected and infected by HIV in the townships and in the villages do not have money. They don't have source of income. Mostly some are breadwinners, so it was difficult for them to be spending money on transport to go and collect medication every single month. NIMART was introduced, and then tenofovir came in. Tenofovir came in to remove Stavodin. It was now a replacement of Stavodin. Stavodin is the drug that we started with in 2004, which had vigorous side effects on people. So we removed Stavodin and we introduced tenofovir. And for the longest time, we've been running with tenofovir, and tenofovir is still one of the drugs that we still use in South Africa. They also changed the prerequisite of CD4 count being 200. They moved it up a little bit to 350. So now we didn't have to wait for your CD4 count to drop to 200 for us to give you treatment. We would give you treatment when the CD4 count is 350, right? Because we realized that, man, it doesn't make sense for us to have to wait for a person to be critically ill to then give them treatment to boost their system. Then we had to upscale. But I would like to believe one of the reasons that not everybody could access ART at the time, I think it might have been, I'm not certain, but it might have been matters of costs. You know, yeah, it might have been matters of cost. Between 2013 and 2014, there was an introduction of fixed dose combination of 3 drugs, and that was amitriptyline, efavirenz, and tenofovir. It is what the nurses call FDC in the facilities. It's a fixed dose combination. We call it TEE. So TEE was introduced between 2013 and 2014. It was a drug that assisted a lot of clients who had pill burden. Pill burden is when a client drinks a lot of pills. So ART consists of three drugs. In special cases, it will consist of 4. But ART, antiretroviral consists of 3 drugs. And at times, you would have to take 2 in the morning, 2 tablets in the morning, 2 tablets at night, 3 tablets at night. And it's exhausting. It was tiring for our people. So they came up with the fixed dose combination, and a lot of people were transferred or changed or switched to the fixed dose combination. I know for a fact that a lot of clients really loved the fixed dose combination. It was effective, it was cost effective, and it was a great drug. And it still is actually. It still is a great drug. And that happened in 2013 to 2014. We also increased the CD4 count criteria. This time around, we took it to 500. We waited for your CD4 count to be less than 500, and then we would initiate you on treatment. But with pregnant women, we ensured that they were getting treatment, or they were getting their ARV drugs as soon as they are diagnosed when pregnant, right? And of course, there are other PMTCT methods that were used prior, because PMTCT was also introduced in 2004. Yep. Definitely, it was, I remember, even though it's not here, but I remember that PMTCT was introduced in 2004, but there was a certain way that PMTCT was done back then, until in 2013 and 2014, when the FDC was being introduced and the CD4 count criteria was increased to less than 500. Pregnant women were then given access to ART regardless of their CD4 count. And also children who were under the age of 5 years, right? As well as people who had co-infection. Co-infection is when a client has TB and HIV, right? I mean, they are coexisting, and that's why we call it co-infection. So clients who had like co-infection, and children under the age of 5 years, pregnant women, and general population who had CD4 count that was less than 500 would access ART between 2013 and 2014. I was in nursing school by then. In 2015 and 2016, that's when I finished nursing school and started working, there was an introduction of what we called universal test and treat policy. I remember when I dropped in the facilities, they were like, everybody that we test, we initiate. Test and treat. We test you, you access your treatment. We don't care what your CD4 count is, we will give you treatment. Even if your CD4 count is 1,230, you are gonna get your treatment today. You test, if you're ready, you take your treatment home, right? That's what we adopted. We also adopted the screening of cryptococcal meningitis. So we now used to check our clients for cryptococcal meningitis, especially clients whose CD4 count was less than 100. Okay, this happened in 2015 and 2016. In 2019 and 2020, we had an introduction to dolutegravir, you guys. That is our latest HIV milestone. I know right now we are on the trials with the HIV vaccine. It's still in the trials, so I don't want to talk about it here. But yeah, in 2019, 2020, dolutegravir, the new baby on the block, arrived. I think it's actually one of my favorite drugs. Yeah, it's definitely one of my favorite drugs. after Abacavir. But dolutegravir came, it's a robust drug. It is extremely robust. By robust, I mean it attacks the virus as earliest as possible. We put you on dolutegravir, and if we were to run your tests, like to check your viral load in 3 months, it would be lower than detectable limit. That's how fast dolutegravir is. So yes, we had an introduction to dolutegravir, and then we also had a national wellness campaign. So these are the milestones that we've had in South Africa as a country on the HIV program, and they make me so happy, you guys. They make me so happy because I do see the light at the end of the tunnel. You know, nurses who were practicing before I could, they like sharing stories with me, and they would tell me how they would do palliative care to patients who were living with HIV before ART arrived. It basically felt like what it feels like, or what it felt like, because COVID, we have it under control now. But how they narrate their story with the epidemic of HIV, I think I had my own experience with COVID, because COVID traumatized me, you guys. Like watching people die while we as healthcare workers, as scientists, people whom went and sat on a stage or stood on a stage and took an oath to save people's lives when we didn't know what to do, when we didn't have answers for our patients. I mean, I didn't have answers for my patients, and that was something I was not used to. That was something they didn't teach me at nursing school. At nursing school, they never said to me there's going to be a point where a new disease comes in and you won't know nothing about it, and people are going to be dying like flies. So when people tell me or narrate, like the old nurses narrate the HIV story before the ARVs, it felt like how it felt like with my experience with COVID. And truly, to now be here and be amongst the people who are trying to combat the spread of HIV in the country, and to actually see in paper where we come from as a country and where we are now and where we are headed in the future, it really makes me happy. And I just want to say happy World AIDS Day to people who are living with HIV and people who are affected by HIV. And for you to be affected, you don't necessarily have to have a family member who has HIV. By virtue of being in a country that has 7.5 million people living with HIV, that makes you affected. It affects you one way or the other. It definitely does affect you. And I just want to say happy, 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 happy World AIDS Day. May we conquer this disease. May we take cautious decisions on daily basis to work towards eradicating it in our motherland, you know. I personally strongly believe that we are the generation that's going to end HIV. We've got various ways, you guys, of preventing ourselves from the disease. You guys know we've got condoms, we've got the Me First condoms. I don't know why didn't I bring them on my station, on my filming stations, but we've got the Me First condoms, we've got the Max condoms. Our condoms even comes with lubricants now. Lubricant basically reduces the chances of condom burst. So we no longer want you to come in our facilities saying, oh, Sister Z, condom ipamukile, or Sister Z, condom itubehile. We no longer want you to experience those, because those actually do put you at risk of getting HIV. That's why our condoms now don't come alone, but they come with lubricants, okay? So you can go to your nearest clinic, ask for Max condoms together with their lubes. Please do mention that you would like to get lubricants as well, because the Max condoms do not come with lubricants in their packs. Their lubricants come separately. But with the Me First condoms, they come with their lubricants on the packs. Me First campaigns are available in a lot of provinces in South Africa. So if you know any Me First campaign, you can go and ask for your condoms. Guys, we've got PrEP. We have PrEP, guys, pre-exposure prophylaxis. It's available for everyone, okay? If you know that you are at risk of getting HIV, be it you have multiple sex partners, be it you have a partner who is living with HIV, like you are in a discontent couple relationship, be it you know that you are at risk, be it you are a sex worker, be it you are a man who sleeps with other men, and we know the dynamics of relationships amongst men who sleeps with other men, right? If you know that you are at risk, be it you are breastfeeding and you know that your baby daddy whom you are sleeping with without a condom is not someone that is faithful, be it you are pregnant and you know that you might be at risk of getting HIV, please get yourself on PrEP. It's available in all your facilities, in all your Department of Health facilities. It is for free. It is also available to the implementing partners of DOH, like these mobile clinics that you see in the townships, these mobile tents, you know, the gazebos that you see in town, in the malls offering HIV testing. Please go there and ask for an HIV test. When they are done, ask them to link you to PrEP, or to give you PrEP if you are HIV negative. PrEP is a pill that prevents you from getting HIV if you get exposed to HIV. You drink it every single day. It starts to kick into your system after 7 days of initiation. So if you get initiated today and you start drinking it today, after 7 days it's gonna start working in your system and it protects you from getting HIV. To men, please do circumcise. Circumcision reduces chances of you getting HIV. I think I've shared quite a lot of things when it comes to methods of preventing yourself from getting infected. And to people who are living with HIV, all you have to do is to adhere to your treatment. It will benefit you, it will benefit your future babies, it will also benefit your partner. Do you know why? Because undetectable viral load is equals to untransmittable viral load. U is equals to U. So yes, let us adhere to our treatment. Let us not forget to condomize even though we are living with HIV. Just because you're living with HIV doesn't mean you cannot get HIV infection from someone else whose viral load is not suppressed. It is what we call reinfection, where an HIV positive person gives another HIV positive person their own virus. So it might cause treatment failure. We don't want any of that. Let us love one another, let us educate one another, and let us stop the spread of HIV in our country and in our continent. Until next time, I will see you guys on my next video.